A space for conversation around women's health through the lens of naturopathic and Eastern medicine. I am Sandy Ross, and this is Her Earth Medicine Podcast. This podcast is multi-leveled. Episodes for patient education to graduate practitioner level. Thank you for tuning in, and I hope you gain value from this episode. Today on the podcast, I am chatting all things thyroid disease with Tara Nelson. Tara is a naturopath with over 25 years of clinical experience. Her specialty of working with thyroid disease came from her own health journeys when she was diagnosed with thyroiditis. Tara is well known in the naturopathic realm of supporting practitioners, and she runs regular courses on how practitioners can support their patients with thyroid disease. And she also hosts her own course for patients to support their healing journey of thyroid disease. So let's dive in and talk all things thyroid with Tara Nelson. Welcome to the Her Earth Medicine Podcast, Tara.
Hi, thanks for having me. I'm really excited to be here.
Thanks for joining us, Tara. Now, today we're going to be chatting all things thyroid. Do you want to maybe give us a bit of background about yourself and how you became a thyroid expert?
Yeah, sure. Well, I've been practicing for, sort of over 25 years now, and just in clinic. And I just noticed a really big influx of thyroid conditions into my clinic, and just all of a sudden. So I, probably saw, thyroid cases here and there, and it was probably really around about 5 to 7 years ago. I just really noticed this massive influx of thyroid conditions. Probably, I think the first week I saw 15 cases, and it was just like, okay, what's going on here? At the time I was, obviously being face-to-face clinician for that many years, I was in a place where I was looking for something new, maybe to diversify or change tact a bit. Even though I've always had a pretty busy clinic, I've been in the same town and have lots of really good referral partners. I was just feeling like, right, what's next for me? And so I saw a lot of these thyroid, and I really found that I was seeing really tricky and complex cases. So, seeing, a young guy of I think he was about 23 walking in with a TSH of 209, and he was actually, came in with his printed TSH handout. He wasn't even offered thyroxine. He wasn't offered any more follow-up, just, here you go, you got a TSH of 209. And just, just really complex cases, and, cases where I really was sitting there looking at that person thinking, oh, you must have a thyroid condition. But then when I did the testing, the results looked fine on paper. And go, okay, well, what's going on there? And also seeing, a really heavy pathology, so antibodies in the thousands, 13,000, TSH really high, so a really bad case I would see on paper of, say, Hashimotos, but they were symptom-free. So I just saw these really wide variety of thyroid conditions and hypothyroidism grave cases, and I really felt inequipped to deal with the cases, and just felt like my training, when I was looking at the protocols, I just felt that they lacked substance. They were all pretty much, they really reminded me of, it was almost like just just give a thyroid sort of synergistic formula, which is pretty much just like giving thyroxine without sort of looking at the underlying causes. So I went back to do a lot of study, threw myself into really researching because I really wanted to help these people. I then also discovered along the way that I had Hashimotos, and also discovered along the way that my 16-year-old daughter at the time had Hashimotos, which really drove down that idea that there were so many people walking around with an undiagnosed thyroid condition due to the way that thyroid is treated in the medical profession and the way that it's tested. So that just really confirmed to me that, I really needed to get this information out there. Just really started to attract more and more thyroid cases into clinic. I really, at the moment, am only seeing thyroid cases around Australia and internationally, have a big international following, so constantly seeing people online overseas with a thyroid condition, and now anything else coming into my clinic, I'm referring on to other practitioners than just seeing thyroid. and then also saw that need to, support practitioners as well, because I feel like the training that we all had and still are receiving just doesn't cover the complexity that thyroid really needs to have when you want to treat it effectively.
Yeah, great. That's so good that you're training practitioners, because it is lacking in the areas that we kind of get educated on it in college. Now, do you reckon there's been a rise, or does the data show there's been a rise in thyroid conditions, or are you just attracting more because you're specialising in this, from when you first started out?
Well, I think both, but there is definitely a rise. Like the statistics definitely show a really big rise in thyroid conditions. Also, the amount of children being diagnosed and the amount of babies being born with congenital hypothyroidism. So, yes, there is definitely a big rise in the statistics. But, yeah, I'm definitely, it's on my radar. And I think if you talk to most practitioners, you'll see that we're all seeing more thyroid cases in clinic than we ever did before. So
why do you think there is a rise in thyroid disease?
Well, I think number one, it would have to be awareness. I think we are getting, it's getting out there. You can, there's a lot of information online now about the thyroid and people, and I think with the age of the internet and, being online and that sort of awareness, there is more information for people to Google and look at. So that's, and with people going, oh, maybe I do have a thyroid condition. But I think across the board, we're seeing, the biggest rises are due to the toxic world that we do live in. That includes, the toxic chemicals, over 80,000 chemicals in our daily environment that we're exposed to more and more that we were never exposed to in previous years. The vascularity, the little thyroid gland sits in the neck and it's highly vascular, so it's very sensitive. It's often called the environmental sensing gland. It's hugely sensitive to toxins. So we see those toxins in, our water, in food that we eat, in the processed food. We see it in the environment, in the air. We see it in, the cars, the furniture, the carpets, our building products. It's just everywhere at the moment. In the plastics, it's everywhere. And the gland is super sensitive to that. So I think it's definitely number one. And then just going a little further on that idea is a lot of those environmental chemicals are things that are called allergens, and they're actually on the sort of the same periodic table as iodine. So a lot of those chemicals actually displace iodine, and we know iodine is one of the really big minerals that are needed to make, combined with tyrosine to make our thyroid hormone. So it really, a lot of those things like our fluoride, our heavy metals, our industrial chemicals, our flame retardants, bromide and things like that definitely displace our iodine uptake. Then I think that probably the next one is stress and our busy world where, also so super busy and running around and, things like high stress, infections, and the influence of cortisol on the thyroid gland affecting our hormones. So there's that stress aspect and the adrenals being very closely related to the thyroid gland. And then I think the next one would be nutritional deficiencies. So a lot of those things, a lot of our busyness and our toxicity, our poor diets, definitely displaces a lot of need for the optimal nutrients. Our thyroid gland is it needs a lot of nutrients to function well. Combine that with, say, an autoimmune condition, so Hashimotos and Graves, the immune system is a very nutrient-dense system also. So you combine those two sort of systems and you need really, really high nutrients to support thyroid function. And I think, from our, lack of really good diets, we're not getting enough nutrients, and then, possibly, throw gut health in there. That's definitely another trigger as well, poor gut health. So there's quite a few reasons, and I think that's why treating thyroid is so complex, because it is, there's so many reasons. Well, I think in essence it's because the thyroid gland, every cell and tissue in the body needs thyroid hormones to function well. So, there's so many reasons why, the thyroid may not be producing enough hormones to get out to all those body tissues and organ systems.
And do you think that's where there's a correlation with, young children and babies now having thyroid disease, is because, the environment is more toxic? I think they're finding over 200 chemicals in the cord blood. Mothers now, we know that iodine is super important for pregnancy as supplementation because we're not getting enough in the diet. Is there any other correlations there that you find with the kids getting the thyroid disease?
Yeah, definitely. I think, number one, I think is that a lot of women don't know they've got a thyroid condition. So I see a lot of postpartum thyroiditis or, hypothyroidism that is triggered by pregnancy or definitely postpartum or even hypothyroidism and Graves. And I do see, when I look back through the history, there was possibly an underlying thyroid condition there, but and I know that was typically true for myself. When I look back in my health history, I think that my thyroid condition, my Hashimotos, was triggered by my third pregnancy. So I had three kids in 4 years, so it was 3 consecutive pregnancies, three cesareans, because I couldn't birth my children very well because I'm quite a small frame, and breastfeeding all that time as well. And there's a lot of nutrients involved in there, a lot of iodine, a lot of stress when you have babies. So I definitely think, pregnant women are definitely just developing thyroid condition.
Okay, well, I might come back to the pregnancy and ask you a little bit about that in a minute. But can we maybe start with going through a little bit about the physiology of the thyroid for, say, student practitioners or patients that haven't really got an understanding of what the thyroid does in the body?
Yeah, sure. Yeah, so as I said before, it's really important. It's a super important organ, and every cell and tissue in the body requires thyroid hormones. So when the body is sensing, or the brain actually, or the serum, there's low thyroid hormones or high thyroid hormones in the brain, the pituitary gland, which is in the brain, it actually starts in the hypothalamus, and the feedback loop for low thyroid hormones tells this hypothalamus to produce thyroid-releasing hormone, or TRH, which sends a signal to the pituitary to produce a TSH, or a thyroid-stimulating hormone, and the TSH stimulates the thyroid gland to produce, or actually release. So it's already this phase has gone through iodine and trapping and connecting with tyrosine to produce. It's quite a complex interplay within the follicular cells in the gland. But once that feedback loop senses that there's low hormones, it starts with the TRH and then the TSH, and then the thyroid gland will stimulate those T4 and T3 to be released into the bloodstream, and that should go out to where it needs to support the metabolism pretty much of every cell and tissue. As I said before, iodine is a component of both those hormones, T4 and T3, a tyrosine as well, and they really support the body's metabolism, but the body temperature. It's needed to promote healthy heart function. We need it for digestion, brain maturation and growth in children and babies. So and I think that again, when we go back to that, why children are born, is that it's, the thyroid development is so essential for really healthy brain maturation and growth in children and babies. And if you've got a mum that goes into pregnancy with, a subclinical hypothyroidism, which is super common, really more common, I think, than we're picking up and, we're seeing out there, it's the maternal thyroid is struggling already, then it's got to support the fetal thyroid up until about 12, 13 weeks. Even longer, but once that thyroid is formed within the baby, it's still supporting it. And then a lot of the thyroid goes out to lactation and supporting lactation as well postpartum. So it's really, really, and if there's not enough there's low thyroid hormones, a lot of nutrients or things blocking that, that's where those, babies can miss out. We need the thyroid to support healthy nervous function. So, a lot of people with thyroid conditions find that they don't respond well to stress at all. So, so we, as I said, the body, every organ has these thyroid receptors and can be affected by low levels of thyroid hormones there. So that's where we see a lot of symptoms with hypothyroidism and hypothyroidism because of those body systems that are affected by the thyroid.
Okay, thanks for explaining that. And I think once people understand kind of the role and the physiology of the thyroid, where it actually starts much above, hypothalamus then to pituitary, then they can kind of understand when you explain the role that stress has on the hypothalamus. It makes a bit more sense to them if cortisol is probably a bit of a concerning problem there. Could you maybe go through some of the common thyroid diseases and what they present with in clinic with their signs and symptoms?
Yeah, sure. So I guess we'll start with, subclinical hypothyroidism, and just going to grab, I do have like a little cheat sheet that I give out to, I think in my book, I've got run if students don't know, there's a practitioner group called Thyroid Mentoring for Pracs that I run, and all students can join that, or any practitioners. Up in the notes of that, and lots of practices come in and post their cases on there, and we just chat. There's some really great practitioners in there that can help people with their thyroid patients. And I do have in the files section a bit of information. So my thyroid cheat sheet's up there, which kind of goes through all the the diagnoses and thyroid conditions and the ideal lab ranges, and a few, working out iodine ratios and T3 ratios as well. So there's a lot of information on there. So first off, I guess we'll look at subclinical hypothyroidism. So this is a really common one where we see, you might see TSH begin to rise around about sort of 2 or 3, but we're still seeing normal T3 and T4 and no antibodies. So we can start seeing symptoms here, and we'll start to see just a slight rise in that TSH, but normal sort of thyroid hormones. And then these patients can still experience quite a lot of the thyroid symptoms, like they might be starting to, their metabolism slowing down a bit, they might be experiencing brain fog, menstrual irregularities, they might be feeling cold, dry skin, there might be hair changes. And then the next sort of stage is that would be overt hypothyroidism, where we definitely see that TSH rising anywhere sort of above 3 up to 10 or even higher, and then we'll start to see that low T4 and T3 as well, but still there won't be any antibodies. So in hypothyroidism, when the gland is struggling to produce its hormones T4 and T3, so that's when we'll see that high TSH, and that's when the pituitary is getting that signal from the hypothalamus saying, come on, keep whipping the thyroid, because there's low thyroid hormones in the serum. So it's like TSH is the whip for the thyroid. So when we sting that high TSH, we know that gland is struggling. Conversely, when you're looking at hyperthyroidism, we're seeing high hormones. So that feedback loop is going back to the brain saying, nope, there's too many hormones, back off. So we'll see that low TSH. I hope that kind of makes sense, because that took me definitely a while to get my head around what was going on there. And then when Hashimoto's, we see that autoimmune hypothyroid. Again, in Hashimoto's, we can see, the distinguishing factor there is thyroid antibodies, our thyroid peroxidase and our thyroid globulin antibodies above the reference ranges. So usually, the reference ranges have changed. We're seeing different reference ranges at the moment. We're seeing less than 60 or less than 6. So depending on what lab you're actually looking at the moment, I would see it, if there's antibodies that are kind of like, quite a bit over the reference range, then that's Hashimoto's. Again, we can see in Hashimoto's, we can see either a normal TSH or we can see a high TSH. So if there's antibodies and a fairly normal TSH, the glandular function hasn't been impacted yet. And we'll probably see either normal or low T4 and T3. And then we have hyperthyroidism. We can have subclinical hyperthyroidism again, where we're seeing a lower TSH, usually below 0.5, fairly normal in range, T4, T3. The symptoms with hyperthyroidism, we can have fatigue, and actually I didn't say that one of the biggest symptoms of hypothyroidism is fatigue. I think fatigue is in both hyper and hypo. Fatigue, we can have anxiety, we can have loose stools, we can have brittle hair, we can have dry skin, we'll have intolerance to heat, we can have anxiety. That's probably the most common symptoms. And then we have Graves' disease, which is autoimmune hyperthyroid, where we'll still see that TSH below 0.4, and we'll see a rise in that T4 and T3, so quite high T4, T3. And we may or may not see thyroid antibodies, the TPO and the thyroid globulin, but we will see the presence of TRAB, so TRAB antibodies or TSI antibodies, which confirm Graves' disease. We only see TRAB and TSI antibodies in Graves' disease.
Okay, wow, thank you. That's a lot of information. I love the name Graves' disease. It's always one of those things you think, oh gosh, what a terrible name to give a disease. But anyway, so do you find a lot of...
It suits it quite well. Graves' disease is really aggressive, and if you ever see a true Graves patient, they're in a grave way. It's a very aggressive autoimmune. It's very acute. When it first, it's usually caused by like a virus or a stressful period or, leaky gut or a combination of those things, so a toxic exposure, and it comes on really, really fast. That person can go from one day being fine to the next thing just being in a world of pain with anxiety, massive weight loss, muscle wasting, loose stools. It's really quite an aggressive grave disease.
Okay, now you mentioned with Hashimoto's sometimes they can have the normal TSH, but they have the antibodies present. Is that something that's commonly undiagnosed, that people are walking around with Hashimoto's? Because if they go and have their thyroid checked and TSH is in the range, they're probably not going to get their antibodies checked at that point.
Yeah, absolutely. And that's something that I deal with all the time. So people will come in with just that one little marker, TSH, which actually, TSH is definitely part of the picture. It's part of the puzzle. It's part of the thyroid panel, but it is one tiny little marker. So we really need that full thyroid panel, which will include TSH, T3, T4, reverse T3 initially I like to look at just once, and then TPO antibodies and thyroglobulin antibodies. And if you suspect Graves' disease, so if you're seeing a very low TSH or their symptoms fit the hypothyroidism picture, you need to test for TRAB or TSI antibodies, which will confirm the diagnosis of Graves. But I'm constantly seeing people, even people that have had Hashimoto's for a long time, and the GP's fine with their TSH and maybe a T4, but I'm always working on getting those antibodies down or getting them into remission from their autoimmune condition, so I want to see antibodies tested every single time. And I think because of that, because of the way that its testing is run, we are definitely missing out on a lot of diagnosis. And also, I see a lot of patients with hypothyroidism, have had hypothyroidism for years, or they come in, I've got hypothyroidism, I'm taking thyroxine, and I ask, have you had your antibodies tested? And they'll say, no, never. And they've been walking around with an autoimmune condition for years and they don't even know it.
Yeah, right. Okay, so you answered my next question, which was what pathology tests are going to be for the thyroid. But do you add in anything else like ultrasounds or maybe urinary iodine tests or anything else that you didn't mention just there on the pathology testing for the thyroid?
Yeah, definitely. So, full thyroid panel. And usually I will test if they've had a long-standing thyroid condition, or just, I've diagnosed, or I've diagnosed them with a thyroid condition, they've come in with a thyroid condition, and they haven't had an ultrasound, or they haven't had an ultrasound in the last 6 to 12 months, I'll always get an ultrasound just to look at what sort of available tissue does the thyroid have for producing its hormones, because any sort of long-standing thyroid autoimmune condition will degrade and destroy the thyroid tissue and follicular cells, so the inability or its ability to produce thyroid hormones will be reduced. So an ultrasound will tell me how much healthy available tissue do they have to produce hormones. It'll also show me if they have any nodules or cysts or swellings or goiter, and also, rule out thyroid cancers and things like that. So, ultrasound is super important. And, yes, I do always test iodine, mainly for my hypo and Hashimoto's. It is a hugely common deficiency. I use the Naturopathic random urinary, so fasting. I don't do the loading just because I see so many autoimmune clients. I'm not afraid of iodine, and I do use iodine in my hypo and Hashies and with autoimmune conditions, but not so much with Graves. There's different rules for Graves, particularly in that very reactive state. But, I want to see what's going on with their iodine. Urinary iodine is what I test also. Okay. And then I might also, so that's kind of like looking at their thyroid health. I always want to look at liver function there, because a lot of the T4 to T3 conversion happens in the liver. I like to look at all their nutrients, so, vitamin D, B12, zinc. What else do I test for? I think that's the 3 main nutrients I test in the blood: B12, D, zinc, or iron studies. And I might look at the CRP. So, I'm very fortunate to work with GPs in my area and have established really good relationships, so I can get all these things tested for my clients.
That's great. What are some of the core nutrients that the thyroid needs to function healthy?
Yeah, so I think one of the, we've talked about iodine a lot. We know, thyroid hormones require iodine and tyrosine within the follicular cells. So we need the coupling of those two nutrients to actually make our T4 and T3. Around about, I think it's about 65% or more of T4's anatomic weight is made up of iodine. So it's a big, chunk of that. So if you're seeing, a really low T4, say combined with, hair loss or brittle hair, maybe tender breasts, they're my kind of like red flags for testing iodine. Selenium, I would have to say, is a really big one. It would probably be my number one nutrient. Every thyroid condition requires selenium. So it's really important for, oxidative stress. It's a big component in T4 and T3 production, and the conversion of T4 to T3, because that's a common presentation I see also is, people taking as much, they can have as much thyroxine as they want, but if they're not converting it to the active form. So it's T3 that actually gets into the cell to give every cell and tissue its metabolic effect. Because every cell needs thyroid hormones to have a metabolic effect, and but it's actually only the T3 that gets into cells. So we can produce the T4, we can produce a little bit of T3 as well, but that T4 needs to be converted in liver and peripheral tissues to T3. And quite often, many of our patients are not making that conversion. So selenium and zinc are two very vital nutrients for that one. So again, zinc is a really another specific one. Vitamin D is another specific one there. B12, vitamin A, and I think we spoke about tyrosine. So they're probably my key nutrients. And when I'm looking at these nutrients in the blood, I'm looking at optimal levels. So I test iron. Sorry, I didn't mention iron. So I don't actually test for, so iodine I test for in the urine. Selenium I don't test a lot for anymore because it's such a finite reference range. And I see a lot of, excess iodine on blood tests, but I've got a feeling that they're just not getting it, they're not utilising it properly. So I'll always give selenium for my thyroid patients. Iron studies, we want to see ferritin up there around the 50 to the 80 mark. Zinc, we want only up in the above ranges, so about 16. Vitamin D, 100, 120. B12 around about that 600 mark. So when we're looking at nutrients in the blood, I want to see optimal levels, and I'm working with all my patients to get optimal levels, not just in range, not just okay, particularly with, our autoimmune conditions, because a lot of those nutrients support healthy immune function. So when we're looking at autoimmune conditions, it's just the immune system is just so dysregulated and it's burning through all those immune nutrients really fast. So, and then you've got a thyroid that's trying to produce its nutrients and requires all these cofactors. So when we get those nutrients up to those optimal levels, it really makes a difference in our thyroid patients.
Great, and that's some great reference ranges you gave there. With selenium, what kind of dosing are you doing?
So selenium, the RDA is 150 micrograms. With Hashimotos, it just depends on what I'm looking at. If I've got hypothyroidism, everything's going okay, I'll probably stick to the RDA of 150 micrograms. I do in Hashimotos, I might use up to 200 to 300 micrograms. And sometimes in Graves' disease, when I'm seeing a lot, selenium supports thyroid. When you think of we're seeing this overproduction of thyroid hormones, right? So we're burning through, all those nutrients so fast. So selenium is going to be needed in higher and higher amounts. It also helps reduce oxidative stress, inflammation. It's a big antioxidant. So I usually go in with Graves, acute Graves onset with, 300 to 400 micrograms for a little while. Just to really settle things down, and then might drop down that dose. But they're kind of like my maximum. My minimum is 150, my maximum's 400 micrograms.
Okay, good to know, because a lot of patients come in and they're like, I'm taking 3 supplements with the selenium, and they obviously have concern there with the RDA. So thank you for sharing that. Do you use any basal body temperature for charting and monitoring of the thyroid at all?
Yeah, I do like to use basal metabolic temperature testing. It's great for kids. So, if you've got a child that doesn't want to do, the mum's concerned about their thyroid health and, don't want them to have blood tests, or they've got real anxiety, or, just some patients, I might get them to try, we're waiting on tests. Okay, here's the charting. Go away and check your temperature every morning for a good 10 days, and do that every month and see where your temperature's at. So we know that with hypothyroidism, they're going to sit below that normal body temperature range, which is around, I think, about between 35 and 36. And in hyper, we see above the range. And then sometimes it's a really good tracker when if you're seeing someone with a spiky result, so that one day they're in mid-range and the next day they're down the very low temperature, then they spike up to above a high temperature. And so if you've got a spiky up and down like that, that can actually indicate poor adrenal function or stress or cortisol. So it can give us a few little markers there. But, yeah, I definitely do like it. And it's good for tracking. So they can do it I try and get patients to do it every month, and it just gives us a good tracking of their thyroid.
Yeah, and easy to use for kids, so you don't have to draw blood. What are some of your big clinical changes that you treat with when it's an autoimmune condition versus a subclinical thyroid condition?
Yeah, so we're really trying to modulate the immune system, and autoimmunity is the number one cause of a thyroid condition. So autoimmunity is the number one cause of hypothyroidism and the number one cause of hyperthyroidism. So what is triggering? So it's all of my treatments that I go into, it's looking at the nutrients and what's been going on in their history, but it's really important to find out what is causing the thyroid condition in the first place. So it's what is causing the immune system to suddenly trigger and start producing antibodies against its own thyroid tissue. And that when that happens, that degrades the glandular function to either be hypo or hyper. So things like, I work with diet, so there's a role of gluten and dairy, leaky gut. So I'm working with diet a lot. I sometimes bring in the AIP, the autoimmune paleo protocol for diet and lifestyle, which really works with autoimmune patients. I'm looking at specific nutrients such as things like your selenium, your inositol, vitamin D, and then I'm looking at specific herbs as well. We've got beautiful herbs that work on immune modulation, so things like cordyceps and Romania and hemidesmus might be things, or Nigella as well is another nice immune modulator. It really depends on if I'm looking at Hashimotos or Graves is what I'm going to bring there in a herbal.
I can see your lovely little herbal dispensary behind you. It's great. Herbs are amazing with thyroid. Can we maybe move back into pregnancy a little bit? I'd love to hear if there's any kind of clinical considerations you do different with someone that's pregnant that comes in with a thyroid condition. And like you said, it's very common now. People think they're okay, and I mean, they probably just haven't had their bloods checked or checked out the thyroid yet. And then they become pregnant, they do blood work, and they find now that the thyroid has become either over-functioning or under-functioning. What are the differences you would do in clinic treating a pregnancy treating someone with pregnancy versus just someone that's not pregnant?
Sure. Yep. So women who have a thyroid condition in pregnancy, so whether it's triggered by pregnancy or they've come in and I've got a thyroid condition, I'm born to be pregnant, or these women need a lot more support. So they really need a lot of support during their pregnancy and postpartum as well, because they are at risk for postpartum thyroiditis. We want to make sure again that they've got optimal nutrients. I'll speak about that a lot. Particularly if they've got an autoimmune condition. So ideally, I work with these women, if we know they've got a thyroid condition, to get their antibodies down, because there is a lot of risk to mum and bub with high antibodies in pregnancy. There's a miscarriage risk, there's a risk to the fetus and things like that. So working, ideally getting it at the start and managing and then getting pregnant, but that often doesn't happen. I see many women that just come in, I've got a thyroid condition, I've got Hashimotos and I'm pregnant, I've got really high antibodies, but they do need optimal nutrients. So I will be testing these nutrients and particularly their iodine all through their pregnancy.
Okay.
Probably every trimester at their health checks. I want to make sure they've got all those nutrients we've talked about. We can still use things like selenium. We can still use things like vitamin D. The only thing I do probably differently is I don't use herbs.
Okay.
I usually don't use any herbal treatments during pregnancy, but I can pretty much use everything else that I've been using as normal. But I really just make sure that, I'm making sure their diet's really good. I'm looking at managing their stress, making sure they're sleeping really well, and then just really managing their optimal nutrients for thyroid function. We do see a lot of changes in pregnancy with the thyroid panel, so TSH can initially get really quite higher in the first trimester, and there can be a few changes with the thyroid hormones. We actually see a little bit of a lessening of the antibodies. So if someone's going into pregnancy with high antibodies, we actually see that role of pregnancy settling things down. So it's almost like the metabolic changes within the pregnancy just sort of relaxes. The immune system can just relax a bit and just sort of, and then we'd see this kind of, I still work, if I'm still seeing antibodies, high antibody, I'm working on those within pregnancy, and the same as I would with a normal hypo, but just, omitting those herbs.
Okay, now if someone is very nauseous and they're not able to hold down their supplements, and you may have, they're doing acupuncture, they're taking P5P, they're doing all the things that we, getting to eat protein regularly to try and help support the nausea. Is there any kind of compounding or any recommendations you go for there, or iodine under the armpit? What kind of considerations do you apply if someone can't particularly hold down in pregnancy their supplements?
Yeah, I don't do like skin absorptions of nutrients, but we can, I guess, things like magnesium, is okay. I don't really do the iodine under the skin, but we just do the best we can, trying to get in, lots and lots of nutritious food, bone broth, and really working with the diet. And then, smoothies, trying to put things, if there's powders and things like that, into smoothies that they can just sip throughout the day. Yeah, we just try and work with what we can in that sort of situation.
Okay, thank you for sharing that.
I guess trying to work more on, just helping them through that period and lessening that nausea and morning sickness and, Yeah,
it's a tough one, isn't it, when they come in, they're vomiting up their guts and they've got antibodies now present. Poor things. Okay, so let's chat a little bit about gut health and the correlation with thyroid disease, because I know this is a big topic. Shall we start with how is gut health related to thyroid disease?
Yeah, well, gut health is a bit of a two-way street. So, we do need, there's a lot of receptors in the gut and cells that actually need really good thyroid hormones to function well. So, thyroid dysfunction can affect the gut, but also poor gut health will affect, thyroid health. So it's a bit of a two-way street there. And we need a really good supply of thyroid hormones for digestion and motility. So like in hypothyroidism, when there's low thyroid hormones, we see everything slowing down. We can see constipation, poor absorption of nutrients. Conversely, in hypothyroidism, when we're seeing that excessive thyroid hormones, it can cause a lot of loose stool and dysbiosis. So it's a bit of a two-way street. Thyroid can affect... Oh, sorry, I'm just going to drink water. What's my throat? Thyroid hormones affect the release of enzymes within the gastrointestinal tract. So we often see low, hydrochloric acid, beta and hydrochloric acid in thyroid conditions. It's a very common deficiency. Things like when we're seeing constipation across the board, this can, impair hormone clearance throughout, within the bowel and can cause elevations in estrogen, which in turn raises a compound called thyroid binding globulin level. And these actually bind not only estrogen, but also T4. So when we're seeing that slow motility, and then that may affect the rise of other hormones, and then thyroid binding globulin will come in and actually gobble up, our T4. So that's going to cause more low thyroid function, slowing transit time, constipation, inflammation, infections and malabsorption in the gut. A sluggish gallbladder can interfere with liver detoxification and prevent hormones being cleared from the body. And then conversely, hypothyroidism impairs gallbladder function by reducing bile flow. So it's a real two-way street. So these, poor digestive function, leaky gut, intestinal permeability. We know that's a trigger for autoimmunity as well. There is, I've read a lot of research around all autoimmune thyroid conditions beginning in the gut, but sometimes I'm not so sure about that one, but not everyone. But there's definitely a role there with gut health, and it's if someone's definitely experiencing gut symptoms, I will definitely prioritise working on repairing the gut while I'm working on thyroid function as well.
It's interesting you mentioned iodine and stomach acid, because I think it's a precursor too. So are you using many functional...
For a low gut function, we're not going to be absorbing, or assimilating those nutrients and absorbing those from our food. So it's definitely, when we're looking at optimal thyroid nutrients, we look towards the gut, right? And we want to really make sure the gut is working well. So all that nutritious food we're going to be recommending for our thyroid patients to eat, we're getting all those really good nutrients from it.
Now, for the gut, are you using any functional testing for it? Are you doing CDSA or microbiome or any other functional tests correlated to the thyroid patient that you see? Are you using?
Yeah, so generally run my standard tests I can get through the GP, and then we'll look towards what's actually going on within that patient to what else I need to test. So I do like the CDSA too. This is a real good, start for someone to test what's going on. Other tests I might, just to rule out things like, we can rule out things like parasites through, PCR, which is a bit of we can't get PCR at the moment. We haven't since COVID hit, which is a bit of a bummer. And look at things like, lipase in serum. We can look at H. pylori, because H. pylori is a common, gastrointestinal infection that will affect thyroid function. There's some research around it, the two-way street there. So I do as much through blood and the GP as I can to go through Medicare. Then, if I'm definitely seeing, I'm thinking parasites or low stomach acid, I'll run a CDSA too. Sometimes if they've got a lot of menstrual irregularities, I look at salivary hormones. So doing the female hormones through saliva, sometimes cortisol hormones as well. I'll combine those two tests as well.
Okay, great. Yeah, I'm such a fan of that CDSA level 2 with the inhibitions. It's so good.
It's great.
Now, what is the correlation between gliadin and gluten with the thyroid disease?
Yeah. So, we know that gluten is that protein found in wheat that causes, gluten is that, we're going to look at what the significance of thyroid, but we know that gluten can cause intestinal damage and affects the gut's ability to absorb nutrients. So, right from the start, it's a really hard protein to break down. It affects our gut lining, can cause, intestinal damage and inflammation. It's also inflammatory. And when I'm asking my patient, when I'm talking to my patients, it's like, is it the gluten? Is it the glyphosate that's sprayed on, our crops? And other chemicals and other pesticides that's aggravating our gut? Or is it the preservatives? So, I do a lot of hair testing. That's another test I use, the 500 hair test.
Okay.
So when I'm looking at diet, I might just do gluten-free, dairy-free and food intolerance testing. But if they have very high antibodies and I think they're a willing candidate, I'll look at the AIP protocol. But when I do the hair testing, and it always comes up with supermarket white and wholemeal bread. And, I say to my clients, like, that bread is, it's like a chemical shitstorm, is what I call it, because it's just basically a processed product. It's got, wheat, gluten, glyphosate, pesticides. It's got colours, preservatives. They mix it with water, chuck it in the oven, and it lasts for a week on your shelf. So there's so many things in that bread that you could be reacting to. But in particular, and the GMOs, let's not forget the GMOs in there as well. But the actual studies around, gluten and thyroid there is this molecular mimicry or cross-reactivity with gluten and thyroid tissue. So gluten, the actual structure, when you look at the chemical structure of gluten under a microscope, and you actually look at thyroid tissue, their structure is very chemically similar or molecularly similar. So when you have, either Hashimotos or Graves' disease and your immune system is dysregulated and it's making against thyroid tissue. When you eat gluten and those big protein molecules go into the immune system, the immune system sees that as similar to thyroid tissue and will ramp up its autoimmune attack against thyroid tissue. Also, something to consider is celiac disease and thyroid conditions often go hand in hand. They're two conditions that we often see running together. Yeah. And there's a lot of studies around showing a strong link between autoimmune thyroid disease and gluten intolerance.
Yeah, okay, that's great information. Do you often test patients for celiac disease or the gene?
I do. Yep. A lot of my clients that come in are already, mostly gluten-free anyway. And, one doctor I was working with recently just, always sort of tested the celiac serology, but a lot of my patients weren't eating enough gluten to get a positive result. So, yes, I normally go straight for the HLA-DQ gene test. And then if that's a positive, I just say to them, it's a gene. We know that in presence of gene, you may not have celiac disease, but in the presence of a gene, and if you eat gluten, a bit leaky gut, a bit of stress, you can switch on, celiac disease very easily. So
yeah, and then you don't need to inflame them with getting them to eat all the gluten-y foods.
Yes.
What are some of your other dietary recommendations for thyroid disease? So you've mentioned gluten-free, and I think that's such a big one. You mentioned dairy. What are the other things that you're using through the diet to heal the thyroid?
So I'll start off with gluten-free, dairy-free. I like to test for food intolerances. So if someone... it just helps support their gut health. It helps support inflammation. It just helps to settle everything down. And then, if I am seeing really high antibodies, and I know that patient is willing and they're already sort of gluten-free or dairy-free, and they could do it, then I will get them to do the autoimmune paleo protocol for maybe 3, 4, 5 months max, which can really bring dramatic results. But that's a very restrictive diet. I don't do it with everyone. And as I said, that I kind of know that person sitting in front of me if they can do that or not. And then I kind of look to specifically what's going. Are we treating hypothyroidism or are we treating hyper? So for hyperthyroidism, for example, they really, when you look at the high T4 and T3 causes that excess metabolism. So it's like running a marathon while you're standing still, and we see that increased need for protein, and we see a lot of muscle wasting. So what we call catabolism. So these guys, hypothyroidism and Graves' disease, need a very high protein diet. So I'll do, a common one I'll do is 5 small meals a day with protein in every meal and snack. Sometimes even 6 if they're not sleeping well, I'll add in a little protein snack as well before bed. That works really well, and it's supplying your thyroid with constant nutrients. Another little tip with hypo Graves is that T3 is actually carbohydrate dependent. So if you have an excess like thyroid hormones such as hypothyroid and Graves' disease, actually putting them on a very carbohydrate restrictive diet and increasing their protein will help to suppress their thyroid hormones. So quite often, I saw a guy yesterday in Sydney or online who was diagnosed with hypothyroidism, and he was Indian. And they had, naan bread and rice pretty much at every meal. It's really interesting, the correlation I see with, nationalities that have a lot of, a very carbohydrate-based diet and their incidence of hypothyroidism and Graves' disease. So I had to say to him, we need to cut out all that grain for a while. So when I'm carbohydrate restricting, there's definitely no, rice, pastas, grains. We get rid of all of that. There's even sometimes I'll really lower the fruit. This is when I'm talking about seeing, the T4 up in the 40s and the T3s up in the 20s or 30s. So we're seeing really high thyroid hormones. We really want to suppress the carbohydrates, and it works really, really well while we're increasing the protein. With hyperthyroidism and Hashimotos, very similar, except we actually need more carbohydrate, right? Because we're looking at low thyroid hormones. But I talk to these people about plant carbs. So, sweet potato, including sweet potato, pumpkin, carrot, all our lovely plant carbohydrates, also things like quinoa and brown rice. So making sure they're getting a little bit of that in, maybe lunch and dinner at most sort of meals will help to increase their thyroid hormones. Always talking to them also about, goitrogenic foods. So we need to restrict soy because that can block our iodine uptake. Let's put the theory to bed of we can't eat cruciferous vegetables when we have Hashimotos or hypothyroidism, because that can block those. In the past there's been a bit of research or talk about cruciferous vegetables, our kale, broccoli, cabbage, cauliflower, all those sort of things. They do have slight goitrogenic activity, but if you steam them,
cook them out,
then they're absolutely fine. Yeah, and they do offer a lot of antioxidants and things we want with our thyroid clients. If someone is having raw kale smoothies every day with hypothyroidism and Graves' disease, yeah, that's not cool. But we can actually use a raw kale soy smoothie in hyper and Graves' disease to actually help counteract the effects of those high thyroid hormones. Yeah, so that's something I might bring in for a little while. So the two, I think that what we also need to distinguish, there are real differences between hypothyroidism and hypo and hyper. And I do treat those conditions actually very quite differently, dietary-wise.
Yeah. Are you very strict with stimulants like caffeine in hypothyroidism?
Yes, absolutely. That's one thing that will definitely go. Yeah, I definitely... I probably, if I'm seeing a very acute case of hypograves, very high hormones, I will restrict because it'll just, they've already got a stimulated system. And metabolism, I'll definitely restrict that. But my motto around caffeine for pretty much every patient is, one coffee a day if that's your jam, not on an empty stomach. So I always ask them to, get up and have breakfast, take their supplements and have their 1 cup of coffee kind of 1 hour after breakfast. So they've got something, they've lined their gut with food, they've got something in their bloodstream, because when you get up and have that coffee first thing, you're really causing, cortisol and insulin to rise, and it can affect blood sugar levels throughout the day, and it will affect your gut health on an empty stomach as well.
Great recommendations there, Tara. Thank you. Is there anything else you want to discuss in relation to the thyroid?
Oh, well, I think we've covered quite a lot, really. I guess I just want to say that, it is really complex, and I think we really, when we've got those thyroid patients sitting in front of us, we really need to put our investigator hats on and find the underlying drivers. So we need to look towards the causes, which I guess we haven't really discussed a lot of the actual causes here, but find out why, that person has got the thyroid condition in the first place. And you will be looking at going right back to, to their gestation, when their mum had them in the pregnancy, and their family history and their life traumas and, infections and viruses and things like that. But when you find those really, their underlying drivers and triggers, and you treat them as well as supporting their thyroid health, that's when you get the best results. And I guess just to know that, autoimmunity is the number one cause of either hypothyroidism or hypothyroidism. And if they have antibodies, you really need to work with your clients to get those antibodies down. And I think the aim of us is to get our autoimmune clients into remission. Once they have an autoimmune condition, they'll always have an autoimmune condition. You can never not have an autoimmune condition because the immune system always remembers. So I work with my clients to get them into remission, which means antibodies below the reference range, but that can be triggered by, they have a trauma or some stress or infection. They are at risk of that immune system triggering again. So they just need constant support. They are great clients because we can get really good results for them and make them feel so much better than they're already feeling. And then they'll stick with you because, they're the kind of clients that need that ongoing support, and they're at risk of having flares. And I think that's something we need to probably tell our clients as well, to be really careful that once you've got that autoimmune condition, you really need to take care of yourself and be as healthy as you can be.
So important to acknowledge there, definitely. Now, can you tell us a little bit about, you've got a practitioner training course. Can you share a little bit of information about that?
Yeah, so, as I said at the start of the podcast, that I found a need for, to get this information out there, because a lot of practitioners were just not, asked. There was constantly people in my group asking for information and, where do we find the information? So I developed a 6-week online practitioner thyroid training program. And I'm just about to run the 6th round. So, this is the 6th time I've run it with great numbers. So it's obviously a course that's really needed out there. And we just go through, module 1, we look at the anatomy and physiology, pathophysiology, we look at the causes. We really go into testing and, each, TSH and T3 and T4 and reverse T3 and what it means if it's high or low or in between, or if you're seeing, a low TSH but you've got normal thyroid hormones or antibodies. So we really go into the whole structure. We spent a really long module on causes. So we go through all those underlying drivers, and there's a lot, so many. And we think about that thyroid being in the endocrine system, things like hormones affect it, blood sugars and insulin affect it, stress and brain function affect it. There's so many things that can affect thyroid functioning, and we need to know what those things are. And then we go into, I think module 4 is all about Hashimoto recovery, where we've got treatment protocols. I think we look at thyroid in pregnancy, we look at autoimmunity, look at thyroid nodules. Yeah, it's a really comprehensive course. It's jam-packed. I'm actually in the middle of writing a second one as well, like a advanced thyroid prescribing. But yeah, there's so much to learn about thyroid health. So if anyone's interested in that, I am about to run this round on the 3rd of May, which is very, very soon. But I will be running it again next year as well. So I'm only running it this year because I'm looking at once this year, because I'm looking at doing a round with some UK practitioners in later half of the year, and then I'll be running it again next year if you miss out on this round. But yeah, it's a great little program.
Sounds fantastic. I think it'd be beneficial for new graduates and also anyone really that's out in the field treating thyroid. It sounds like you've very much done your homework in the field.
Yeah, we have a lot of students do it, and I've had, even a lot of experienced practitioners that have done my course and said, wow, that was great, and I actually learned a lot, which is, it's good to know.
I'll be sure to check it out. Now, where can we find you and your course, your website, and how can people get in touch?
Yeah, so I've just done a whole new website and rebranding. So I think just Googling, Tara Nelson, Thyroid Health Naturally on Instagram. TaraNelson.com is my website and Facebook page, Thyroid Health Naturally as well. Just type in Tara Nelson, you should find me. So, Tara Nelson Thyroid, and you should find me somewhere there. And all my courses, I have a practitioner resources page on my website where we've got lots of information for prackies on thyroid health, and also join Thyroid Mentoring for Pracs, which is my Facebook group. We've got over, I think, there's over 1,000 practitioners in there, and it's a busy group. There's always practice posting their thyroid cases. It's a busy little group. So jump in there if you like, and there's lots of support there too.
Awesome. I wish I found you 5 years ago, Tara.
Here I am now.
Yes, awesome. Thank you so much for taking the time this Friday afternoon to come on and share your knowledge. You've really given us some great insight into treating the thyroid disease. I really appreciate it.
Yeah, no problem. Really enjoyed it. Thanks for having me.
Thank you for listening. I have been a practitioner of naturopathic and Chinese medicine for over a decade. I have a master's degree of health science, and I am an academic lecturer at Australia's leading natural medicine college. I am available worldwide online for bookings. Simply go to sandyrothhealth.com.